Ladies and gentlemen, thank you for standing by. Welcome to the CDC Perinatal Quality Collaborative webinar. During the presentation, all participants will be in a listen-only mode. Afterwards, we will conduct a question-and-answer session. At that time, if you have a question, please press star followed by the number 1 on your telephone keypad. You may also enter questions at any time throughout the webinar by using the chat feature located in the lower left-hand corner of your screen. If you need to reach an operator at any time, please press star 0. As a reminder, this conference is being recorded. Thursday, June 2nd, 2016. I would now like to turn the conference over to Dr. Henderson. Please go ahead.
Good afternoon. My name is Jaquiba Henderson, and I lead the activities in support of state-based perinatal quality collaboratives in the Division of Reproductive Health here at CDC. And I'd like to welcome you to today's presentation for the CDC Perinatal Quality Collaborative webinar series. Today's webcast will be an informative presentation of current activities to address maternal mortality and severe maternal morbidity, and the development, collaborative nature, and national scope of the Alliance for Innovation on Maternal Health, also known as the AIM program. At the end of the presentation, you will have the opportunity to ask questions and participate in the discussions with the presenter. A recording of this webinar will also be archived on our webpage at www.cdc.gov/reproductive-health/maternal-infant-health/PQC. Handouts were made available with your reminder email after registering for the webinar, and will be made available again to registrants in a follow-up communication after today's webinar. Our presenters for today are Elliot Main and Jean Mahoney. Dr. Elliot Main is the Medical Director of the California Maternal Quality Care Collaborative and has led multiple state and national quality improvement projects. He is also the chair of the California Pregnancy-Associated Mortality Review Committee since its inception in 2004. He is currently clinical professor of obstetrics and gynecology at both University of California, San Francisco and Stanford University. Dr. Main has been actively involved or chaired multiple national committees on maternal quality measurement, including those sponsored by the American College of Obstetricians and Gynecologists, the American Medical Association, the Joint Commission, Leapfrog, and Centers for Medicare and Medicaid Services. In addition, he has co-led a number of national quality initiatives with ACOG, the CDC, and the Maternal Child Health Bureau. In 2013, Dr. Main received the ACOG Distinguished Service Award for his work in quality improvement. Our next speaker will be Jean Mahoney, who is a nurse by training and currently is the Senior Director of Providers Partnership, American College of Obstetricians and Gynecologists, also known as ACOG. ACOG's Providers Partnership, supported in part by the college's annual fund, tackles many issues related to maternal safety and allows the college and the Federal Department of Health and Human Services to coordinate maternal and child health activities between federal and state maternal child health programs. Jean Mahoney is also coordinator of the National Partnership for Maternal Safety and Director and Development Leader of the AIM program. I will now turn the presentation over to Dr. Elliot Main.
Good afternoon and good morning here in California. And on behalf of Jean Mahoney and myself, we want to do this presentation in honor of all the other partners that we have in this project. We are engaging the nursing associations, the midwife associations, AMCHIP, ASTO, many other partners around the country are engaged in this, as well as obviously the CDC and Maternal Child Health Bureau. And this really is the representation of many partners' activities. What I'd like to cover today is some of the U.S. data from maternal mortality and severe morbidity, and the evolution then through the National Partnership for Maternal Safety and the Council for Patient Safety in Women's Healthcare, in which the Alliance for Innovation in Maternal Health, or the AIM project, sits to reside. So we'll go through the resources, how we're doing data-driven quality improvement, some of the measures for the project, our data center, and our national staff. This slide shows the disturbing trends that have been in the newspaper a lot, been in our journals a lot over the last 5 years, which is in contrast to all the other developed countries in the world who have seen declining maternal mortality rates, the U.S. has stood out. In 1990, we were at the head of the pack, but by 2013, we're lagging behind all other developed countries. And this is certainly a concern to every provider of medical care for women in the United States, as well as for our government agencies. There's some debate as to whether the rise is related to administrative data, but in any case, i.e. that we're identifying cases better, but in any case, it's much higher than it should be, and in comparison to every other industrialized country in the world. Furthermore, there's great disparity here. The black-white disparity is 3 to 4 times higher in African American women for maternal mortality. This is in contrast to other measures of pregnancy outcomes where there are also disparities, but those, in contrast, are 1.5 to 2x higher. Prematurity is in that range, even infant mortality, and even cancer deaths are in the 1.5 to 2 times higher, which everyone agrees is much greater than it should be. Here, it's 3 to 4 times higher. So this ends up being probably the greatest disparity of any public health measure in the United States. Mortality is a pretty rare event in today's world, in even countries like the United States. But maternal morbidity occurs 100-fold more commonly. So instead of per 100,000, now we're talking about per 100 here. And as you see, in this same time period, from the 90s up to the mid-2000s, we've seen a doubling of the rate of severe maternal morbidity, which is characterized essentially by transfusions, by ICU admissions, and severe complications of pregnancy, going from 0.7% to 1.6%. Obviously, our pregnant population has been changing. We are working with mothers who are older, more obese, have more underlying medical conditions, hypertension, diabetes, and there are many more who have a prior C-section, which carries its own set of complications. In short, we're not in the best of shape when starting pregnancy. However, age and obesity are risk factors. They're not causes of death. So the implication here is that we need to bring our A game when we're taking care of today's pregnant woman. And we need to practice medicine not in isolated one-on-one fashion, but in a fully developed team. Well, this is actually the U.S. and California's actual numbers. What you see here in red is the rate of maternal mortality from CDC databases for the United States as a whole, going from 9 to 15-ish. California, with 500,000 annual births, which represents 1/8 of all U.S. births, is neck and neck with the U.S. as a whole. A little bit more, a little bit less, but rising in the same exact pattern. As was noted, I chaired the Maternal Mortality Review Committee for California, and when we started reviewing the deaths after the state noticed the rise in 2005, 2006, we wanted to look beyond just the epidemiology of the deaths, but look at the opportunities for improvement, trying to turn the mortality reviews into a driver for change. When you look at maternal mortality at the specific underlying causes, in the red column here, you see that the embolic disorders, infection, hemorrhage, and preeclampsia all are in that 10 to 15% range. Some studies a little bit more, some studies a little bit less. Many of them combine inappropriately venous thromboembolism and amniotic fluid embolism, very different disorders, but they often end up being joined together. What you see and what is found in California was the number one disorder is cardiac disease. This is both cardiomyopathy and underlying cardiac disease. And I think this reflects an increasing burden of obesity and hypertension. And in our finding was even more of a concern in the African American population. Now when you go to the next column though, in the orange header, which is one measure of severe morbidity, which is ICU admission, this is now 1 to 2 per 1,000 or 10-fold higher than mortality rate. Here the hemorrhage and preeclampsia now are becoming dominant with some 60% of cases that get admitted to the ICU are from these two causes. The CDC definition of severe maternal morbidity, which includes transfusions and a variety of diagnoses, pretty severe, but a little, but more common, 1 to 2 per 100 now, again 10-fold higher than ICU admissions. Hemorrhage and preeclampsia now account for some 80% of cases. So this is quite directive in terms of where we need to focus our efforts. When you look at preventability for maternal death, there have been 3 good studies, sizable studies. The CDC, working with North Carolina data, tried to identify causes that were preventable, identified hemorrhage and preeclampsia as the most preventable causes. In our California reviews, we looked at a little bit differently. It was hard to retrospectively judge preventability, and we chose to grade the chance to alter the outcome as good, as strong, good, or some, or none. And here we've combined the strong and good chance to alter the outcome. And again, hemorrhage and preeclampsia are the most important ones. The UK looks at it differently again, with substandard care that had a major contribution to the maternal death. And preeclampsia was the most common cause, fitting that category, with hemorrhage in a close second place. They had done previously a fair amount of work on hemorrhage, which is why perhaps that was somewhat a lower cost there. The costs of hemorrhage and hypertension are actually also pretty dramatic here. These were 2 cost analysis studies done recently at UCLA Center for Health Policy Research, indicating that for our Medicaid agency, Medi-Cal, the annual cost for maternal hemorrhage was over $100 million. The annual cost for hypertension disorders was $107 million, both combining the mother and the NICU costs to the baby. So these are real numbers. Now, California has 500,000 births, so you have to prorate that for states. Half of our births are to Medi-Cal. So this was just the Medi-Cal births. The savings was costing $200 million each year for each of these 2 causes. So the significant maternal morbidity is a significant driver for cost and morbidity. So to summarize, we have the most preventable causes of maternal mortality are hemorrhage and preeclampsia, the most common causes of severe maternal morbidity, a large driver of cost, and they have high rates of provider quality improvement opportunities, largely summarized by denial and delay. Denial indicating that the providers were assuming that the condition was going to improve on its own, and we just needed to give it more time. And delay is increasing passage of time before you give the medicines or the treatments that are really going to do the job, such as interventions like balloons or further surgery. This has been shown in several studies, California, Illinois, in the Chicago area several times, and in other countries as well. So our approach in California was to reduce maternal mortality and severe maternal morbidity by concentrating first on these two causes of morbidity and mortality. So in 2009, we did a hemorrhage multidisciplinary task force with everyone we could think of in focus on labor and delivery, including obstetricians, anesthesiologists, nurses, midwives, and hospital leaders. That turned into a quality improvement toolkit, which was then tested through 3 multi-hospital collaboratives of 20 to 30 hospitals, and now is in a statewide implementation project with 125 hospitals. The same pattern was used for preeclampsia, and through a task force, a QI toolkit, and a multi-hospital collaborative here. And getting feedback here, it looks like
Excuse me, Elliot. This is Kiva Henderson. I just wanted to inform you that the sound is pretty low. If you could just speak up or come closer to the receiver so we can hear you a bit better.
Really. Going back to where we were with maternal mortality, this is where we were when we started all these processes in California. And then over the next years, we've seen a significant spreading of where we are in California with the rest of the United States. With the U.S. going up to the 19 range and California dropping into the 7. There are multiple things that can account for this change, but certainly the focus on obstetric safety on our units was a significant contributor. Actually focusing on hemorrhage and preeclampsia improves outcomes for other causes of maternal mortality as well, which were developed in the team structure and the safety elements that can apply to all causes. The National Partnership for Maternal Safety was organized as people started seeing the fall in maternal safety and the increase in maternal mortality throughout the country, and represented the union of efforts from the Society of Maternal Fetal Medicine and ACOG, represented here by Barbara Levy, Kate Menard, and Mary Dalton are past presidents of the Society of Maternal Fetal Medicine, and my role as leader of the California Maternal Quality Care Collaborative and working with ACOG. We called for a national commitment to decrease maternal mortality and morbidity by better monitoring severe morbidity, introducing bundles for hemorrhage and hypertension and VTE prevention, and really trying to equip all obstetric units and providers with education and resources needed. We did recognize that half the births in the United States occur in hospitals with fewer than 1,000 deliveries. So this really also then led us to focus on identifying women at highest risk for maternal morbidity to ensure access to appropriate care. So it's one thing to call for a national effort. The other is to put it into play. And how do you mobilize all the organizations needed? And the answer for that is the Council on Patient Safety and Women's Health Care. This engages vice president or above leaders from all the organizations seen on the screen here, which is essentially every professional organization that's engaged in women's health care, from ACOG to the osteopathic colleges for obstetrics and gynecology, to the anesthesiology societies, the nursing societies, the midwife societies, and the gynecological societies and family practice, and our boards. So this is a critical group of people to engage and focus on these elements. So if we're going to introduce bundles, we have to define what we're talking about. And what we're looking at with the national safety bundles is a collection of the best practices for improving safety in maternity care that have been vetted previously in large quality improvement collaboratives. So the goal here is to move established guidelines into practice with the standard approach within your institution. These are not meant to be a national protocol that would, one size fits every facility. That would not work given the different level of resources and the different approaches that are available in all of our 4,000 maternity hospitals in the U.S. And they're not new science. They're not new randomized controlled trials. They're really putting what we've learned from previous studies into practice. The safety bundles that have gone through the vetting process at the Council all have the same format. They are structured into 4 domains. They're called the 4 R's. Readiness, recognition, response, and reporting. Every unit is for readiness. Is your team ready for an emergency? And then recognition, how does your team identify patients at risk for experiencing deterioration? And how do you respond then to an emergency? Oftentimes safety bundles just in the past have focused on a response, but we really wanted to focus additionally on making a unit ready and have some early warning or prevention activities as well as response. Above all, though, we have to have an element involving reporting. How are we going to learn and improve from events in our unit? So this is data-driven quality improvement, this is debriefing, this is drilling, and learning from our events. So this is a critical R in our structure. The first bundle approved was the obstetric hemorrhage bundle. And again, these were all multidisciplinary in their construct and in their writing. And this was put on the Patient Safety Council website and actually published in 4 journals at the same time. The Green Journal for Obstetrics, the Nursing Journal, JOGAN, the Midwifery Journal for ACNM, and the Anesthesia Journal, Anesthesia Analgesia for SOAP, and an editorial in the Family Practice Journal. So this was a detailed description was vetted and published in all 4 journals in July of 2015. So we have bundles, and then we're also talking about toolkits. And when we talk about toolkits for quality improvement, this is really a repository, if you would, of detailed examples of all the safety bundle elements, example policies, procedures, pathways, instructions, so that a unit can go to the toolkit, takes what it needs, and really jumpstart their quality improvement process. So this is the goal here is for a guide for bundle implementation. There are several states that have led the way early on in these, California and New York, and now we have additional support from many other states in this area. These are some examples at each of our respective websites, cmccc.org, ACOG District 2 through the ACOG website, the Florida Perinatal Quality Collaborative through their website. All these are easily Googleable. And the playbook for successful elimination of early elective deliveries was one that was a follow-up playbook now for those states that still had troubles with early elective delivery that we helped work on through the National Quality Forum. So the national goals set by the Council are that we want to have 3 bundles implemented in every hospital over the next 3 years, with the initial ones being hemorrhage, preeclampsia, and venous thromboembolism. We have additional targets of first birth C-section and interconceptional care. So how can we possibly reach all the hospitals and all the providers in the United States? And part of the answer is with this group on the phone, on this webinar, and with all the people that we talk to. And it's engaging every organization that we can think of in this quest. And that's where the Alliance for Innovation in Maternal Health comes into play. And this is a cooperative agreement between Maternal Child Health Bureau and the Council on Patient Safety and Women's Healthcare. And it's administrated by the Senior Director at ACOG, which is Jean Mahoney. And the goal of the Alliance for Innovation in Health is over the next 4 years to prevent 1,000 maternal deaths and 100,000 cases of severe maternal morbidity as we look at the CDC definition. Again, we have to engage all our professional organizations, but that's not going to be enough. So the key partners for AIM to put all this together, and here they're in alphabetical order, include the Hospital Association, AMCHIP, ASTO, which is, both of which engage our state health partners, various parts of the Center for some CMS that involve CHIP services and innovations such as the HEN, the CDC, the Joint Commission, and the March of Dimes. So this is really an effort of all these types of organizations with all our professional colleagues. Where we stand with safety bundles now is we've grown and published obstetric hemorrhage, severe hypertension, and venous thromboembolism are all on the AIM website that we'll show in a moment. We also have a key bundle on patient and family and staff support, which is supportive for all the other bundles, recognizing that someone who has a near miss or severe maternal morbidity, or in the worst case, a death, the family and the staff also need support as we work through these processes. One of the later bundles is the safe reduction of primary cesarean births, and that's a whole project on its own. There are safety tools that have been published in this project, including maternal early warning criteria, which are again supportive for all the bundles, as well as a guidance for reviewing cases of severe maternal morbidity. Coming soon are 2 new bundles on reducing disparities in maternity care, which is a critical piece that underscores, again, all of our efforts in all of the bundles. And the last bundle illustrated here is looking at what we can do between pregnancies or pre-pregnancy to optimize women's health prior to conception. So if you have bundles, you have toolkits, then how are you going to get them done? How are you going to get them implemented? And this is the key role of a quality collaborative. In here, we have groups of providers and hospitals working together in an improvement project, or a group of diverse organizations all working together on a topic, typically where one alone would be much less successful. The model we have with AIM is to have the state health department with its resources working with organizations that represent all the providers and all the hospitals. So this is essentially a 3-legged stool bringing together hospitals, hospital associations, all the professional organizations that we spoke of, together with state health departments that are generally the source of their own set of programs as well as their own sources of data. So where we are now with AIM is engaging actively a series of states, Oklahoma, Maryland, Florida, and Illinois. We're engaging some very large health systems through NPIC and its organization of hospitals, and Premier and Trinity. Both of those have independently large data systems that can support such a project as well. We've enrolled, we have 4 additional states that are enrolled and actively moving towards data submission and program development, including Michigan, Mississippi, Louisiana, and New Jersey. We're also looking at some of the territories supported by AMCHIP, including some of the Pacific Islands, and a special project through ACOG trying to see if some of the AIM principles can apply to partner countries in Africa. We're anticipating in the next 6 months or so that additional states will join. South and North Carolina we're having extensive conversations with. And the 2 states that started with Merck for Mother support, New York and California, already have a lot of progress in these areas, already have a lot of data, and we're looking to integrate them in a grandmother type of role in the project. There are other states that are actually quite interested as well. All the states on this slide and all the organizations represent 2.6 million births in the United States, which is about 60% of the births. So I'm going to hand the baton over to Jean at this point.
Okay, thank you. And just to say that all of these states have been contributing to our knowledge base as we move ahead with AIM. And so we really want to be thankful, particularly of our grandmother and grandfather states and those states that have been working on bundles and these processes for quite a while. That we don't start the initiative, we just work with it. Next slide, Ellie. So how does AIM work, or why does it work? And we think about this because, number one, we have a national focus. It's not just one state or one system or one hospital. It's not a one-off. We're really looking across the country and trying to build that tipping point across the country of maternal safety as we go. We build, as I said, on existing structures. We're not trying to reinvent wheels. We're just trying to take what's available and to integrate it in across the country. And we really provide cross-facility system and state sharing for mutual support. It's a big, huge thing. And as we go along, I'll talk a little bit more about that mutual and peer support that we're doing. We have an expanding library of resources, and you'll see those. And then really looking on the one-on-one technical assistance that we can provide. Next. And so what's our process? So we've recognized that every single hospital in this country is different. There is no single path that seems to work for any one particular hospital, one particular system, one particular state. And so what we're trying to do is build on what's already existing. We don't try to make it all look vanilla. We do like Rocky Road. So we expect that adoption of bundles is going to be incremental. It certainly isn't feasible to just take all the bundles and do them at the same time and expect that you're not going to drive the world crazy. So just taking one step at a time, one of those bullet points in a bundle at a time, and seeing how that goes, and then building on a success from there. As I say, we learn from each other. We definitely involve patients and families, and you'll see a little bit more about that as we move along. And we like to keep everybody informed of what's going on. Next. Okay, so what do we have available? And I'm going to go through these a little bit. So we have lots of resources, as I mentioned before. So we have in the safety bundles, we have sample protocols, checklists, algorithms, a lot of patient information systems. We have our partner teams, and we schedule TA calls. There's now 8 of them a month that are happening for various groups of people in various systems in various hospitals across the country that we continue to try and keep up with. And these TA calls are, although we facilitate them, it's really those on the phone that are helping each other to build on what they're going on. We take all the information that we get from these calls and try to find out what it is that AIM can do to help break through some barriers. And it's been really exciting to be on them. So as I say, we do these facility-level peer-to-peer support. We have e-learning modules, and if you haven't been on the website, I encourage you to do so. The website is Safe Healthcare for Every Woman, and there's a special spot there for AIM. So that's the council website address that I'm giving you, but AIM is right on the council website. And in those are e-learning modules. Right now we have one on early warning systems, hemorrhage and hypertension. The one on safe reduction of primary C-sections is just about finished and ready to go up. VTE prevention is right behind it. And we'll have others as we move along. And we have the data portal and data manager that Elliot's going to talk to you about. We have a safety action series. It's usually twice a month. We help with the council to put on these webinars that go along, and we have experts that have been involved with the bundle development or bundle implementation that are talking on the webinar about how they're doing and what they're doing. So they're very specific to the bundles. And we are working on doing drill and team training resources, and that's coming in the near future. Elliot? Next.
Thank you, Jean. This is a picture of the website that has many of the resources that Jean spoke about. It's all laid out, all publicly available. This drills down to show you some of the further details on the website. Here are the e-modules. Again, anybody can download these to get these going. We really are excited by these e-modules. And lastly, this is login to support for if you're a member, you can get a member of AIM, you can get a lot of support through this kind of a portal. Each section in every bundle has direct links to the tools needed for implementation. So we talked about obstetric hemorrhage. Here you see the readiness piece. And here are a set of resources that you can immediately link to and download that was supported from sort of highlights of the other states' toolkits. We have a series of longer presentations that are 45 minutes to an hour that are expert discussions on the bundles or pieces of the bundles. Again, these are downloadable, including the slide sets for these. This is a very exciting piece. A question on the table is, are CEUs offered on the e-module courses? And I think Jean can answer that.
On the e-modules, no, we do not have CEUs, but what we do have on the e-modules, they're very short. They're like little TED Talks. And what we do have on them is after each of the domains, so after readiness for hemorrhage, we have a set of questions that hospital staff can print out and then get a certificate that they've accomplished this for their competency requirements within their unit. So we don't have CEUs or CMEs, but we do have these that are very important for the Joint Commission when they're coming around to look at staff education. We are also working, about to work with HealthStream, which is an organization that helps hospital education training. And they also give out certificates. And this is going to be connected with HealthStream to make it even more seamless within a hospital for staff education.
So what's even more important than CMEs for physicians nowadays is actually help in their maintenance of certification process. And we and others on the AIM program have been working with ABOG, the American Board of Obstetrics and Gynecology, for their to make it easy to get credit for QI activities for that part of the maintenance of certification. This has been done for pediatrics and many other specialties, and ABOG is getting on board here, and our partner organization in Illinois has gotten this organized, and we're spreading this around. So that is a hallmark of quality improvement, is to share all the materials far and wide.
Just along with that, I've just been talking with the American College of Nurse Midwives, and they have a similar process, and we're going to work with them to see how we can help them to also get this certification.
So I'm going to spend just a few moments on the data side of AIM, because that's how you can measure progress and how you can measure success. And these are a combination of outcome, process, and structure measures. You really have to have data to drive quality and safety. On the other hand, you want to minimize the effort to minimize the burdens on hospitals and states. And so we strove to strike a balance on that with our experience in multiple quality improvement projects over the last decade. So the overarching outcome measures, consistent with the goals I spoke of at the beginning, are severe maternal morbidity using the CDC definition, which is calculated using patient discharge diagnosis data alone. So that's no additional data collection at the hospital level. Of course, we want maternal mortality, but that's a whole process in itself that we have to get working with state departments of health. For bundle-specific outcome measures, we have 3 bundles that we're starting with right now: hemorrhage, preeclampsia, and cesarean section reduction. These also can be collected with administrative data: severe maternal morbidity among hemorrhage cases, among preeclampsia cases, and then the NTSV C-section rate, which can be calculated with birth certificate data. The hospitals themselves submit through our AIM data portal a limited group of structure and process measures that are focused on education, and essentially only one process measure per bundle that would be collected and reported on a quarterly basis. The data center has built on the experience of many of the other quality collaborators to use run charts illustrated here, showing which your hospital compared to other like hospitals and where it stands within the different quartiles. Data can be presented in a tabular portion, and again, this is a sample hospital, and it would be compared against the state of Oklahoma versus other like hospitals in Oklahoma. Hospitals are de-identified in this process. Hospitals can see their own name and how they compare, but other hospitals cannot see each other's names or even their numerator and denominator. So there's good anonymity here. We do categorize hospitals into the quartiles, the U.S. quartiles. So a quarter of U.S. hospitals are under 500 births, a quarter of U.S. hospitals are between 500 and 1,000, etc. State coordinators, as we work with different state projects, can see the hospital names and to help move them along in a state collaborative, but as we sit at our national levels, we can't see any hospital's names, and no one else can see the hospital's names. So this is an example of a hospital, seeing how it compares to other hospitals. The different shades of purple here represent the different types or the different levels of births at each hospital. And so a hospital here, Tillman Care Center, would see its own name and its own rank and its own rate. And it could, at the bottom here, select or deselect various hospitals to narrow the process down. So now we're only looking at 1,000, 2,000, and over 2,000, and that allows you to do the comparisons a little bit more clearly. We are very interested in disparities, as I mentioned at the beginning of our discussion today, and we're following that both at the hospital, which probably only can be done at an annual basis given the sample sizes engaged, and collaborative-wise. So we're looking to try and reduce not only maternal morbidity overall, but maternal morbidities among African Americans and reduce that disparity. Here's an example of a process, one of the few process measures that we have, which would be nurse education on a given bundle in increments of 10%. And again, you can compare yourself to the different strata of hospitals, and you can see in this, at this point, about half the hospitals are engaged and have completely done their nursing education. So when you look at provider education, they're lagging a bit behind. Here we're asking that they have had at least a grand rounds, or attendance at a grand rounds, or other educational activity related to the specific bundle. Implementation is hard, though, and it's one thing to have a bundle, one thing to have a toolkit and even data collection, but the actual implementation is where most folks struggle. And so what we see here is the ability to put together resources that have been very recently done. The CDC has done a very nice project of developing the Sustaining Perinatal Quality Collaborative that was released just 2 months ago. That is helpful for states, but also is very helpful for implementation of specific projects. The Council on Patient Safety and Women's Healthcare has a bundle about bundles, if you would, a bundle of how to implement bundles, or at least a toolkit on that, and that was released just 2 days ago. It's on our website, and that has a lot of very practical information. CMQCC has also, in the last days, released an implementation guide for supporting the vaginal birth and reducing primary cesarean toolkit and our collaboratives on that. So these are great resources to go through as you're working either at the state level or the hospital level to work on the implementation phase. Just as we're closing, I'd like to recognize the staff for AIM that's national here. Jean Mahoney is on our line today. Kisha Seminuk is our program manager who does a lot of the day-to-day interaction. Martha Nago is program associate that gets all our materials up and a lot of the communication. I'm working on the implementation side. Andrew Carpenter and his associates at Critical Junction have developed the data center and are managing that, and are working with state agencies to get the birth certificate data and the patient discharge diagnosis data. But we could not do this without all the national and state leaders from ACOG, A1, ACNM, AMCHIP, ASTO, and many other related organizations to make this really fly. So what we covered today was U.S. data for maternal mortality and severe morbidity, the National Partnership for Maternal Safety, and how that's come under the umbrella of the Council of Patient Safety, which is now contracted with AIM to roll this out nationally. We've talked about how we're in 8 states right now and looking for funding for more, and hopefully we'll get more states and more funding, and all the resources that we've already developed that are available on the Council website, on the AIM portion of the Council website. We have a data center up and running, and we're collecting data now from multiple states. And we'd like to end with a thank you for all of our partners and encourage everyone to get engaged. And I think we have we have 7 or 8 minutes left that we can handle questions as we go along.
Hello, Elliot. This is Kiva Henderson. I just want to let everyone know that we are taking questions in the chat, and we will also be taking live questions. I also would like to ask the operator to open the lines for questions for those who would like to actually engage the speakers through the audio lines. And I also want to ask, if you are not speaking, to make sure your phone is on mute. So Elliot, there are some questions we already have in the queue, and I'll just start with those questions. We actually do have longer than in a few minutes. We have time for a question and answer until 3:30, but we'll take the questions that we have already lined up. The first question is, what went into determining selecting the health conditions, for example, hypertension or obstetric hemorrhage?
So those were identified, hemorrhage and hypertension, as that they were the leading preventable causes of maternal mortality. They were far and away the most important causes of severe maternal morbidity, accounting for over 80%. And they had a high degree of preventability. They also contributed a lot to extra costs for labor and delivery. So those were all wrapped up into the highest, creating them as the highest priority. In California, we're also working on a toolkit for cardiovascular disease, which, as you noted, was the #1 cause of maternal mortality, but it actually encompasses a whole range of conditions. It's not a single, even cardiomyopathy actually breaks down to 4 or 5 different types of cardiomyopathy: hypertensive cardiomyopathy, pregnancy-related cardiomyopathy, hypertrophic cardiomyopathy, for example. And so it gets complex very quickly, and it involves a lot of people outside of the hospital, which is a trickier part to reach. So we're working on different strategies for that than we can use for hypertension and preeclampsia, which are largely focused on the hospital and the prenatal care immediately prior to the hospital.
Thank you very much. Our next question is, would HealthStream access require a purchase by the facility, or is access to HealthStream adequate? Thank you.
So, hi, this is Jean, and I'll answer that question. So we are just contracting now with HealthStream, but from what I understand, if a facility is already using HealthStream, it will just be part of the package that comes with it. So it's not a specific separate package. And HealthStream will be doing webinars and other things to help promote AIM once it gets started. So we're really excited to be working with them.
Fantastic, thank you.
Mm-hmm.
So the next question is in relation to the bundle. And the question is, are we collecting neonatal outcome during the bundle use time? And I assume this is in regard to the maternal project. The maternal project are neonatal outcomes being collected.
Yeah. State health departments are collecting that for states as a whole. Neonatal mortality rates, of course, but we're not collecting additional neonatal morbidity issues. This has been a focus largely on the maternity outcomes. In California, as we focus on cesarean section, we are, in our collaboratives, we are looking at a variety of neonatal morbidity outcomes as a balancing measure. And we're looking at ways of expanding that up for other states to use using administrative data.
Fantastic. And then the last chat question that we currently have is, how will you make sure that data isn't double counted? For instance, in Maryland, the largest birthing hospital with approximately 10,000 births a year is a Trinity facility, and Trinity is also participating.
Okay. Well, we have some hospitals that are both in a state and in a health system. We are looking to encourage them to be primarily counted in their state if they're in a state like Maryland. They will be displayed in both, but we are counting them for if they're in a state in the state. The data portal can display them again in both, so they can participate in both, but the actual counts will be limited to the state, unless there's in a system that's not that doesn't have a state home as well. There was a chat question I saw about the definition of severe maternal morbidity. Severe maternal morbidity is obviously a spectrum of gradations from almost died, near miss, to morbidities that could be just vaginal lacerations. And so where you actually make that cut point in between is recognized to be arbitrary. We wanted to have two goals. We wanted to have it be severe morbidity and not very milder morbidity, and we wanted it to be measurable. One of the definitions of near miss that we use for case review for the Joint Commission is 4 units of blood transfusion or ICU admission. Neither of those is easily captured with administrative data. In fact, both of those can be very hard even for a hospital to identify internally. It's sort of interesting how difficult it is to get blood transfusion counts from many hospitals. So we partnered with the CDC to use their measure that Bill Callahan developed a number of years ago with Elena Kuklina, and is done on administrative data in California, which is the Severe Maternal Morbidity CDC Index, if you would. We actually just did a validation study that was published in May, suggesting that it was a very adequate measure. It's not perfect. We felt that there was severe maternal morbidity was probably not best defined by a single unit of blood transfusion, which would be counted in the CDC. But on the other hand, families and patients might consider any blood transfusion a pretty. So it was a test of sensitivity and specificity. If you did include 1 unit of blood transfusion in the mix, it is collectible, and it is, and we have worked with a collaboration of 4 or 5 state projects with the CDC to validate a transition to ICD-10. And that involves some tweaks of the definition and the codes, and that will be released shortly. So we do have an ICD-9, ICD-10 version of severe maternal morbidity that has a track record, that has 10 or 15 publications on it. So that's the one we're using for this project.
Fantastic. I'd just like to remind participants that we are still accepting questions through the chat function, and I believe the operator has opened the lines for audio questions. I also would like to remind you that handouts were made available in the reminder email for those who registered, and will be made available again to those who have registered for this webinar after the presentation. There will be handouts with the slides made available, and the presentation will also be posted on our webpage. The link to our webpage is on the last slide that's currently presented, and you can also sign up on our webpage to get notifications for any updates or changes to that page. So we'll go ahead to the next question, and the next question is maternal mortality data collected in U.S. territories, for example, Puerto Rico and U.S. Virgin Islands?
I actually don't know the question. I'm assuming it must be, because that is a basic public health measure. But
yes, I can answer that. That question is yes. The answer is yes, but I'm sorry.
Go ahead, finish.
No, I was just saying that the simple answer is yes.
So I'm looking at the list that's in acute care settings, at what gestational age should fetal demise be investigated? That's a little off of our topic today, but generally at hospitals, we often investigate 20 weeks or more. There's a big move nationally to move that down to 16
pick
weeks.
Up the Northern Mariana Islands is one of our
Yeah, that's there's some very good new data on stillbirths that's come out of the NICHD Collaborative on Stillbirths.
And
so Jean, I think we're hearing you talk in the background.
Yes, please mute your phone if you're not answering the question.
And the next question here is, will you be counting all blood products in the 4-unit count with the recent discussions about plasma versus packed cells? So any blood transfusion counts as a severe maternal morbidity. The 4-unit count was for the Joint Commission. And the Joint Commission wanted folks to look at basically considered a sentinel event with a thorough investigation, formerly known as a root cause analysis, now a little bit more broadly defined. But it was a multidisciplinary review of the potential systems improvements. So that's what the 4-unit count is. It's in, working with the Joint Commission and ACOG, we revised it to be simply 4 units of red cells, easier to collect, easier to count, because what about, platelets come in 10 packs, is that 1 or is that 10? And cryo can come similarly. So it was really focused on red cells, just as an arbitrary item. We do strongly recommend fresh frozen plasma, but this gets away from all those other issues.
Thank you. I just want to let participants know, if you'd like to ask an audio question, you can just press *1 in order to be queued up for an audio question. Are there any additional questions at this time?
And there are no audio questions at this time.
Thank you. So if there are no further questions at this time, I'd like to thank, sorry, is that a question? Okay. We would like to thank Elliot Main and Jean Mahoney for giving us an excellent presentation on the Alliance for Innovation on Maternal Health. We'd also like to thank you all for participating in this webinar, and we'd like to invite you to provide feedback about this presentation and this webinar series as a whole. We will be contacting you after this webinar for your input. We hope that our webpage and this webinar series will facilitate exchange of information and promote visibility of perinatal quality improvement activities throughout the country. You may also visit our webpage at www.cdc.gov/reproductive health/maternal infant health/PQC to learn more about CDC support of perinatal quality improvement collaboratives. Thank you again, and have a wonderful afternoon.